Now we invite Dr. Pankaj Jain from Vadodara to deliver his talk on MAFLD. Dr. Pankaj Jain is MD/DM Gastroenterology and Hepatology from GB Pant Hospital, and he is a senior consultant gastroenterologist at Sterling Hospital, Vadodara.
This one. Okay, thank you. So good evening, everybody. First of all, I would like to thank you all who are still present in the hall since afternoon in spite of repeated brain hammering. And I would like to be attentive now because now in the coming 15 minutes, we will be dealing with the disease of ourselves in the future. Probably this is the disease which will affect everybody. So this disease is named as MAFLD, that is metabolism associated fatty liver disease. What is an update? Previously, the disease known as a NAFLD, non-alcoholic fatty liver disease. Then why there was a need for changing the name from NAFLD to MAFLD, that is metabolic associated fatty liver disease? Because NAFLD practically is the diagnosis of exclusion, when we try to exclude every other thing and then we label the fat in the liver as a fatty liver disease and when there is inflammation. But ultimately it has been seen that even in the fatty liver disease, non-alcoholic fatty liver disease, there was a definition for the safe amount of alcohol. And subsequently it has been proved that there is no safe limit of alcohol use, not 30 gram in the female, not 60 gram in the male, because it is in the heterogeneous population, the effect of alcohol is totally different in different populations. So there is no safe limit for the alcohol use, which has been demonstrated in many studies. And now, many times it has been seen that this NAFLD has been associated with the diabetes or some metabolic abnormality. So that's why there was a lot of metabolic dysfunction that triggers again the accumulation of fat in the liver and then further inflammation. That's why in the repeated conferences and consensus, it has been seems appropriate that we eliminate the alcohol both from the name and from the definition. This would open the door to develop and implement a positive criteria how to assess the fat accumulation in the liver and further the development. So now, after a brainwashing and repeated consensus formation in 2020, the scientists has come across the definition, any kind of hepatic steatosis in the adult, which can be detected by either imaging, blood biomarkers, or scores in the liver histology, and is combined with any of the above parameters, that whether it is associated with the type 2 diabetes, whether they are obese, or if they are normal weight and associated with any of the two metabolic abnormalities where the waist circumference is more, blood pressure is more, plasma triglyceride is more than 150, HDL less than 40, pre-diabetic, HOMA level more than 2.5, and high sensitivity CRP is more than 2. So practically we all are falling in the same scenario. So that's why probably this is the disease of the future which will be affecting everyone. And this is not the case. If we look at the prevalence is continuously increasing from 15% in 2005 to almost 32.4%. The alarming situation. And coincidentally, diabetes and obesity associated in more than 50%. And if we look at the NAFLD cases itself, then there is an association of up to 76%. No age group is a bar. If we look in India, the north region and the coastal region, probably the availability of more rice and more wheat is causing the more fat accumulation in the liver. Why there is an accumulation of fat and why there is a lot of inflammation? The simple pathogenesis, there is a increased excessive production of reactive oxygen species, and this reactive increased oxygen species leads to increased lipid peroxidation. And when there is a lipid peroxidation increases, then there are cascades of events, in case the inflammation, in case the fibrosis, in case cell death, all occurs. So is there any difference in our understanding between the NAFLD and MAFLD? Yes. In NAFLD, it has been shown that only the accumulation of fat which causes the further heat. So there is only two heat phenomena where our understanding has increased, and in MAFLD, we incorporate the gut-liver axis, we incorporate the genetic factor, we incorporate the environmental factors. So practically, many factors had been incorporated to understand the disease pathophysiology, pathogenesis, and ultimately cell death and fibrosis. So after having this background, now look at the diagnosis. What we have in armamentarium to diagnose. We have the simple test, the AST/ALT level. Pros and cons has been written, but probably the liver fat cannot be measured. Only there is a MRI which measure the fat in the liver. We can quantify the fat in the liver by the MRI, but MRI is expensive. So we rely on the other factors or the combination of the factors. Just for enumeration, this is AST/ALT, ultrasound, CT, MRI. Transient elastography is a widely available test and combine all the scoring systems in the plasma. Probably these are the armamentarium and non-invasive tests which are available for us. Roll-up liver biopsies still exist. Even having all the non-invasive tests, we have the liver biopsy, which always remains a gold standard to diagnose the wide spectrum of disease. So liver biopsy is still considered in patients with fatty liver who are at increased risk of having development of NASH after the fatty liver. And why it is important to diagnose the fibrosis in the liver? It has been very well shown that as the fibrosis increases from F0 to F1 to F2 to F4, the actual survival is decreased. Whether you correlate with the liver biopsy, whether you correlate with the transient elastography. So as the fibrosis level increases, the mortality and morbidity both increases with time. So it is very important to know how much the fibrosis if we have a fat accumulation in the liver. So these are the summary of the common tests which are available. Some tests, fibrogen 4, very high sensitivity, NAFLD score, APRI score, very good bedside test. Some serum tests, FibroSure and ELF. FibroScan is readily available, and liver biopsy. So look here, FibroScan has the highest sensitivity, and fibrogen 4 has the highest specificity, 93%. And if the cutoff level is less than 1.3, you can really say that patient is not having any kind of fibrosis in the liver, where the upper limit of more than 2.67 always say there is a fibrosis in the liver, whether it is a grade 2, grade 3, grade 4, is always indicate the fibrosis. And when you combine it with the other tests, it will further increase the sensitivity. So I think if you are utilizing second NIT for a person who are falling in the gray zone or indeterminate zone or indeterminate criteria, then probably you increase your sensitivity further up to 5 times. So it is always good to combine some NIT, one NIT with the other NIT, that is non-invasive test for the metabolism-associated fatty liver disease. So I think, what are the factors which predicts the further progression of the accumulation of fat in the liver to a disease state like inflammation, fibrosis, and ultimately the cirrhosis? So this is a need of we should all know. So there are a lot of literature available, but I have just come across the ABIDE model, which I find out very accurate and just a newer one, which incorporate almost 6 parameters: AST/ALT ratio, bilirubin, INR, diabetes, esophageal varices, and the grading has been given accordingly, and we can calculate the score in the ABIDE model. Validation, very good validation with 95% confidence interval. At the 5-year and 10-year, we can say if more than 4.1% of score, then having a very, very high risk of hepatic decompensation means very, very high risk of progression of the disease. If less, then less chances. After this background, now look at the treatment modalities which are available right now. I think in a MAFLD, we should attack a 3-prong, multiple prong should be there to attack on the fat accumulation of the liver. First is lifestyle modification. Obviously, I would like to emphasize on body weight reducing, diet, exercise, smoking, alcohol quitting. Then there's a pharmacological intervention. And lastly, bariatric surgery to decrease the weight. This slide is very important to show us what is the importance of weight loss and lifestyle modification on the amount of inflammation in the liver and amount of fibrosis. I think less than 3%, almost negligible effect, but in between 5 to 10%, if you are losing your 10% weight, then probably fibrosis reduction is much more, and this will remain sustained even after at the end of the year. So probably your goal should be to lose your weight between 5 to 10% so that you can achieve a good amount of suppression of the liver inflammation as well as the fibrosis. So mind it, you have to aim for 5 to 10% of reduction in the body weight. Vitamin E. Vitamin E is a very good drug approved by the FDA in non-diabetic patient, act as an antioxidant property to reduce the fat inflammation. Management of dyslipidemia, I think everybody of us knows how to treat dyslipidemia, statins with, but one thing I would like to say, statin itself has some anti-inflammatory and antioxidant property directly on the liver, apart from reducing all the fats. Fibrates, again, it's when you combine it with the statins, probably it has some synergistic effect. Pentoxifylline has been used in rampant of the study, in rampants of the trial, and probably it has proved to be effective in any kind of disease because it decreases the inflammation. Very good drug, thiazolidine, PAPA2 agonist, significant diminish the insulin resistance, very well approved by the FDA in the range of 15 to 45 milligram, along with the GLP receptor agonist, which will be used in the diabetes and obesity management. And this is the final slide, AASLD slide, which recommends the use of pioglitazone, FDA-approved drug, and which reduce, except the fibrosis, it reduces every parameter of the fat inflammation in the liver. Second is vitamin E, but it is used in non-diabetic patient, and these all categories of drugs are used in diabetes with obesity. The naming is liraglutide, semaglutide, and empagliflozin and dapagliflozin. These are the newer drugs which are on trial. I would not like to emphasize further obeticholic acid. We all know the companies are promoting. Another most important drug which is available in India is saroglitazar. I think in my clinical practice, this is a wonderful drug because it has significantly reduced the liver inflammation. Maybe it is with diabetes, maybe it is without diabetes, maybe it is with obesity, maybe it is without obesity. I have my own data of 200 patients, and this is a recent paper from Kolkata on the saroglitazar, which shows that even at the 24-week and 52-week, there is significant reduction in the fibrosis score, as well as there is significant reduction in the AST and ALT. It means there is significant reduction in the inflammation also. The few words about intestinal microbiota, because we are encompassing so many things. If there's a dysregulation of the intestinal bacteria, if there's a dysbiosis, then probably the liver inflammation will be increased. And genetic determination are also there, yes. So finally, screening all patients with type 2 diabetes and pre-diabetes, even with the normal liver enzyme, should be screened for the liver fibrosis. All patients who are diabetes or pre-diabetic with an abnormal liver enzyme and more high fibrosis score should be screened for the other causes of the liver disease. All patients with diabetic and pre-diabetic and with high fibrosis score should be sent to the hepatologist and gastroenterologist for further assessment. Thank you. I would end my lecture with just two quotes in Hindi. चीनी खाओ तो चलो फिरो, घी खाओ तो दौड़ो भागो, बैठना बीमारी को बुलाना है, बैठना मौत को बढ़ाना है. Thank you.
Thank you, Dr. Pankaj. Can you elaborate something on the FibroSure test?
Sir, FibroSure test is a serum test which encompasses 5 or 6 parameters, which is available with some sophisticated lab. If you give a blood sample, they will give you FibroSure score, and the score by score you can interpret. There are ASTLT level, platelet level, then the INR level, then the bilirubin level. So 5 to 6 parameters are being incorporated in the FibroSure score, and they interpret by themselves and give you the score.
Most of the drugs that we used in MAFLD in patients with diabetes are common to diabetes and MAFLD. Is there any additional drug that we can do besides that?
I think it's still not available in US is the saroglitazar, which I am using very rampantly in last 3 to 4 years, and I found it to be very useful.
Thank you.
Pardon, sir? Sir, Gilbert is a metabolic disorder which is because of the glucuronase kinase enzyme deficiency disorder, in which the bilirubin level remains static. Whenever there is a stress, there is any kind of stress to the liver, the bilirubin goes up, and that is the indirect bilirubin. That is the unconjugated bilirubin goes up, and it doesn't have any detrimental effect throughout the life on the liver. So maybe sometime you might have the enzyme elevation in the liver because of the inflammation, because of the surrounding environmental factor, but not because of the disease per se. I think there's a separate session on the diet part, which they have kept. UDCA is not effective, sir. UDCA has been prescribed by physician and by so many other colleagues because of the no reason.
Trivedi, yeah.
Because of the no reason. I don't find it useful. Yes.
Thank you. In whatever ways you want to control your diet, the dictum and proven by scientific studies is you have to lose 700 kilocalories per day in your total dietary intake, so that is the better than any of the drugs. Ultimately, if you lose say around 7 to 8 kg, all diabetics, as you know better than me, that diabetics they almost become pre-diabetic. Same applies to this, because the insulin resistance will go down, and that is the basic reason. Sorry for interruption. Lean bodies, the definition of the lean body is what? Is it with a truncal obesity or not? That is $1 million question. Number one, we Indians, we have a truncal obesity. And number two, sonography has 30% false positivity rate of fatty liver. Remember this finding. For 30% false positive.
Thank you, sir. Yes, sir. At no stage we should leave untreatable. Because even if after F4 stage, there is a... Sir, even after F4 stage, there is still a lot of scope available to slip the liver into the end stage liver disease, where there is a refractory ascites, there is a refractory hematemesis, recurrent HE, and there is a prolonged coagulopathy. So that is the stage where we should ask the relative that, look, take him home and...
Excuse me, sessions. Can be discussed at leisure, I think. Sorry about this. Thank you so much.
Sir, every
Pankaj.
kind of fatty liver disease should be treated if there is an inflammation. And inflammation is to be measured at least with so many parameters available, because ASTLT every 3 monthly, if you are not getting ASTLT level normal, then every 3 monthly you have to measure. You have to do a liver biopsy to see the inflammation, staging of the inflammation. And though so many markers are available also to get the liver is inflamed. And even if you are getting the liver is having fibrosis, then you can treat with the inflammation. So liver biopsy is a good choice if you really want to know whether the liver is inflamed or not. Thank you, sir.
Thank you, Dr. Pankaj, for the